I'd now like to invite the first formal presentation of the day emanating from our research, and that's to welcome Dr. Michelle Barrow, CNELM's Academic Team Director and Clinical Director. Her roles also include leading the program leader for the BSc Honours Nutritional Science. She is our link tutor between CNELM and Middlesex University and a research supervisor. So lots going on for Michelle in her roles. Michelle is also a registered nutritional therapist and runs her own nutritional therapy clinic. And she sits on the editorial board of Banch Nutrition Evidence database. And Michelle, as part of her doctorate studies, was looking at personalised nutrition practice as part of CNELM's research agenda, and will present today on some of those findings of transforming personalised nutrition practice. Welcome, Michelle.
Thank you, Kate. And thank you as well, James, Adrian and Addy, for your interesting presentations. My presentation is on the research project that I undertook for my doctorate in professional studies at Middlesex University. The title of my doctorate was Transforming Personalised Nutrition Practice, and the title of the project was Constructing Validated Clinical Tools to Enable the Development of a New Evidence Base for Personalised Nutrition Practice in Obesity Management. The observation which led to this research was that nutrition practitioners were really good at using evidence to make intervention decisions, but were not gathering any evidence on the efficacy of their interventions. Therefore, constructing new standardized clinical tools for health data collection, clinical decision-making, and clinical outcome analysis could help standardize data collection methods, as well as enable assessment of the efficacy of interventions, and could also facilitate the development of a new case-by-case evidence base for personalized nutrition practice by pooling the standardized clinical data sets. And when that data set is big enough and robust enough, as James explained, statistical machine learning may enable us to make predictions on the outcomes of interventions. The project's research questions were: is it possible and ethical to standardize data collection methods in personalized nutrition practice? And if so, what tools can be constructed and validated to help individual health history data collection, clinical decision-making, and clinical outcome analysis to enable the development of a case-by-case evidence base for personalised nutrition practice in the management of obesity. So really, it's about building an evidence base to underpin nutrition therapy practice to help move from anecdote to data sets. It is essentially aspiring towards predictive translational bioinformatics, which was what James was talking about. So really, you can see here that standardized data collection would inform clinical practice, which is, the bedside arm of the translational loop, as well as inform predictive models and help to create a new evidence base for practice, which would in turn inform clinical practice. And that's the translational loop. And as James mentioned, it's really that 2015 paper by Zidi et al. In Cell called Personalised Nutrition by Prediction of Glycemic Responses that really demonstrated how to do this, and that does fit with James's slide. So my research design was a mixed methods collaborative 5-stage approach, and it had interim reflexivity and project progression tracking. There was an extensive literature review to inform the project approach, as well as tool development and to help answer the research questions. The data gathering included online searches to gather, categorize, and evaluate existing validated and non-validated tools. There are also surveys and interviews to experience the use of tools or tool development or to inform new tool construction. The interviews with practitioners selectively sampled a range of nutrition practitioners, including dietitians, nutrition therapists, and a weight loss coach. And interviews with academics and statisticians were also selectively sampled to evaluate their experience of tool development. The third stage was a Delphi survey method for tool development, which is a multi-staged collaborative survey method, which aims to achieve consensus for new tool development. There were 17 participants on the Delphi panel, including kind of 5 clinical patients who were kind of looking to manage obesity or were seeking for weight loss. There were 7 nutrition practitioners, including a dietitian, 2 weight management consultants, a nutritionist, a nutritional therapist, a deputy head of care, as well as a GP reviewing the tools from a clinical perspective. There were also academics. There's 1 statistician, 1 information systems management expert, and an obesity researcher who was also a member of the Association for Nutrition. And yes, they all helped develop the new clinical tools through this kind of iterative survey approach until everybody was kind of in agreement, at which point we tried to pilot trial the new tools in practitioner clinical settings through kind of nutritional therapists. However, there were numerous barriers to engagement, and the pilot trial didn't really go anywhere. And as a result of that, the evaluation arm of the research was designed in response to the pilot trial outcomes to evaluate ways in which standardized tools can be embedded into personalized nutrition practice. And this included a survey of practitioners, as well as 6 interviews with a range of nutrition practitioners to identify the barriers to engagement with the pilot trial. There were numerous challenges and limitations throughout the project. Of course, obesity provided a focus for the scope and of the project and a definable target group. It has a complex etiology and comorbidity, so it's representative of a range of health conditions, but really the choice of obesity impacted the research because it was condition focused, which isn't what personalized nutrition is about. The project was, very complex, and that impacted on participation, and really a lack of understanding impacted the depth of interview discussions. In terms of the pilot trial, I really should have gone directly to the target population to validate the tools. Practitioners are not researchers, so that's that's one of the reasons why the pilot trial didn't work. In terms of the Delphi survey and the pilot trial, there's obviously this conflict between simple tools that are easy to use, but also the requirement for comprehensive and robust tools, which meant that the tools that were developed as part of this research project through the Delphi process, which is supposed to narrow things down, actually got bigger and bigger and bigger. It was the final part, the evaluation part, that really allowed me to understand how practitioners use tools to support their practice approach. And I have to say that, in tool development, there was a lot of limitations around kind of physiological mechanism research, which CNELM have been working hard to improve. There were limited clinical questions surrounding mechanistic reasoning around inflammation and blood sugar regulation. And those questions really had to be created from scratch for the new tools. There were lots of challenges along the way. We don't really have time to review them all, but I will touch on the last one, which was, if we're measuring the outcomes of nutrition interventions, really, how do we measure the therapeutic relationship, which was also huge in nutritional therapy practice. So this is a visual representation of the results of the 5 stages of the methodology. All stages gave insight on defining what is meant by personalised nutrition practice, as well as the development of the vision for transforming nutrition practice and how clinical practice and data gathering work in reality. Stage 1 and 2 really started to address the research question on whether it's possible and ethical to standardise data collection methods in personalised nutrition practice. Stages 2 to 5 unveiled the barriers to implementing standardised data collection in clinical practice. And the stage 4, which was the clinical trial, it was not possible to achieve validity, and clearly the tools that were created were not usable in practice due to the lack of engagement with the pilot trial. But stage 5 gave a lot of clarity in terms of what the issues were and how to overcome them. So, as a kind of outcome, it is possible to standardise data collection in personalised nutrition practice without compromising a person-centred or personalised practice approach. Ethically, you could argue it is important to standardise data collection to build evidence of efficacy in practice, to reduce practice variation and improve patient safety. So rather than have large single clinic questionnaires, it is possible to build a range of clinical tools which can support both standardised and personalised data collection approaches. There are, however, other ethical issues to overcome that are not insurmountable, but these are related to kind of data ownership, data protection, and consent in relation to data mining. So, what tools can be constructed? Well, single tools that don't take more than half an hour to complete on goals, behaviours, health history, family history. So, a range of clinical tools that are can be negotiated as to when the client fills them in. So in essence, you have a range of tools and you can do kind of personalised, standardised data collection by only having specific tools for specific clients. But of course, there is a need for some core tools. Online real-time smartphone applications can help overcome current research limitations. The pathophysiological mechanisms, tools that ask questions that gather data to support pathophysiological reasoning can be corroborated with laboratory tests to measure validity. And of course, it's again that ZV paper, the approach to observe and predict using statistical machine learning can then validate observation with cohort studies and undertake personalised clinical trials, as James explained. So to conclude, the project did achieve its aims, but was unable to validate any clinically useful tools. Instead, it really created an understanding of how to develop a new case-by-case evidence base to support personalised nutrition practice. It was the first research project which aimed to synthesise different nutrition practice approaches to support the development of a robust translational bioinformatics tool using pathophysiological reasoning. And it did create new knowledge on the practical, ethical, professional, and institutional implications on what it would take to develop a personalised nutrition practice model. This paper was published in 2020. As a result of this project, it sets out the strengths and limitations of current approaches to clinical nutrition practice and the underpinning research. It describes how personalised nutrition practice approach supported by evidence-based pathophysiological reasoning could direct research, which could then transform practice. It explores pooling N=1 data into case-by-case evidence database that uses computational network modelling to predict the efficacy of personalised nutrition interventions and the prediction of the efficacy of interventions should also be validated using, where possible, blinded, randomized, controlled, stratified intervention studies. This paper justifies why an evidence-based personalised approach should use the robust, standardised and validated tools that gather patients' signs and symptoms, health history, family history, genetics, environment, lifestyle, social life, diet, behaviour, and all the other factors that have an impact on physiological processes, and that it should also gather anthropometric measures as well as functional, diagnostic and prognostic biomarkers for pathophysiological mechanisms. It was really the CNELM position paper of the vision we have for personalised nutrition practice. We continue to explore the clinical utility and user experience of a range of kind of small and numerous clinical data collection tools through the supervised clinic at CNELM as part of our kind of ongoing research. We have this pilot trial running at the moment. My references, I will take questions at the next delegate Q&A slot. So as Chris mentioned, please do add any questions to the Q&A facility. Thank you very much.